Hey everyone, welcome back. I'm so glad you're here for part 5 of our Explainer series. Today, we're putting on our detective hats and totally demystifying the low complexity category on the medical decision-making, or MDM, grid. We're going to take a super targeted look at exactly what pushes an encounter into this specific level, break down the actual rules from the AMA guidelines, and figure out how to properly audit these presentations without second-guessing ourselves.
All right, let's just dive right in. Here's our roadmap for today. We're going to hit the intro to low complexity, acute uncomplicated illnesses, hospital observation and admission, defining acute stable illness, run through a practical chart audit walkthrough, and wrap it all up with a 3-point audit checklist. Quick and focused.
Section 1. Intro to low complexity. Let's put on our auditor hats and define the boundaries.
So, what actually makes a problem low complexity? Think of it this way. To master the MDM grid, you have to remember we're looking exclusively at short-term problems. The keyword here is short-term. These are conditions with a low risk of morbidity and honestly little to no risk of mortality as long as they get treated. The real anchor here, we fully expect the patient to bounce back completely with zero permanent functional impairment. If there's a higher risk or permanent damage is on the table, we are instantly out of low complexity territory.
Now, how do we actually prove the provider did the work? We rely on the MEAT criteria. And no, we're not talking about your lunch. Monitor, evaluate, assess, and treat. It's the absolute required framework to prove a problem was actually addressed. You know this, but I've got to say it. Just dropping a diagnosis onto a chart doesn't count. As auditors, we need to see the meat. Are they checking lab results, assessing the test they just ordered, actually prescribing a treatment? If it's not managed using these criteria, it literally does not count toward the complexity level.
Moving right along into Section 2, acute uncomplicated illnesses. Think about those everyday bread-and-butter cases you see all the time. By the book, an acute uncomplicated illness is a self-limited or minor problem. But here's the catch. It's not resolving consistent with a definite and prescribed course. That specific phrase right there, that should be setting off alarm bells in your auditor brain. It basically means the patient had a minor issue, it's just not going away like everyone thought it would, and now they need a real clinical evaluation and a treatment plan to get them over the finish line.
Let's make this super concrete with some common examples. We're talking about things like uncomplicated cystitis, allergic rhinitis, simple sprains, viral upper respiratory infections, superficial lacerations. You see the pattern, right? These usually affect just one part of the body, they respond really well to basic treatments, and they have a short, sudden onset. They definitely don't drag on for months or years. That is your classic acute uncomplicated issue.
Section 3, hospital observation and admission. Let's throw a bit of a clinical curveball into the mix. So, what happens when an uncomplicated illness lands a patient in a hospital bed? It feels like a huge contradiction, right? Your gut reaction might be, well, they're admitted, so the complexity has to be high. But hold on a second. We really need to look at exactly why they are in that bed.
Actually, hospitalists report this quite a bit when an otherwise healthy patient is just waiting. Maybe they're pending placement, or there's a shortage of skilled nursing facility beds. Sometimes they just need some basic supervision rather than intense critical medical care. The severity of their illness didn't just magically skyrocket to high complexity just because they needed a step-down bed for the night. Remember, we are coding the complexity of the problem addressed, not the building the patient happens to be sleeping in.
Section 4. Defining acute stable illness. This marks a subtle but totally crucial shift.
Okay, an acute stable illness is defined as a new or recent problem where treatment has already been kicked off. And here is the golden nugget. The patient is improved and clinically stable. Now, they don't have to be 100% magically cured to be considered stable. But as an auditor, you absolutely must see clear documentation that the treatment is working and the patient is on the mend.
Let's put these side by side to really lock it in. An acute, uncomplicated illness, that's a recent problem that still needs an initial evaluation and a definitive treatment plan because it's just not going away on its own. And acute, stable illness, on the flip side, means the treatment engine is already running and the chart proves they are getting better. Cementing this difference in your head is a total game changer. It'll make your Table A audits so much faster.
Section 5. Practical chart audit walkthrough. Time to take all this theory and actually apply it.
All right, here's our scenario. We've got a 15-year-old female coming in with a worsening cough, sore throat, and a runny nose for about 3 days. The physical exam shows a general normal appearance. She's in no acute distress. It's a super standard everyday visit. Let's see how the provider documented the plan and how we, as auditors, translate that.
Breaking this down step by step. The provider's assessment is viral upper respiratory tract infection. So, as auditors, we translate that straight into our Table A category, acute uncomplicated illness. Short-term, low risk. Then we check the plan. They ordered a SARS-CoV-2 RNA test and gave supportive care instructions. Does that hit our meet criteria? Absolutely. They're evaluating with the test and treating with supportive care. The problem is definitively managed, boom, validating it as a low-complexity problem addressed.
Section 6. 3-point audit checklist. Let's get you some actionable takeaways.
I highly recommend using this quick mental flowchart on your very next shift. Step 1, weed out the fluff. Pinpoint exactly which conditions were actually managed using our MEET criteria. Step 2, look at that pared down list and identify the types of conditions. Is it a minor issue? Is it acute? Step 3, validate if that acute condition is uncomplicated, meaning it needs a new plan, or stable, meaning the current plan is working. Stick to those 3 steps and you're golden.
Before we completely wrap this section, we've got to talk about the absolute golden rule of EM coding. Listing problems, diagnoses, or symptoms will not increase the level of service. Copy-pasting a massive problem list does not equal high complexity. If they're listing 20 symptoms but not actively managing them with monitor, evaluate, assess, or treat protocols, it does 0 to elevate your MDM level. End of story.
And that is the perfect jumping-off point for what's next. In part 6 of this explainer, we're flipping to the completely other side of the grid. We're going to tackle managing stable chronic conditions, specifically diving into a single chronic problem versus multiple chronic problems. It's a whole different ballgame when you introduce long-term disease management, so you'll definitely want to stick around for how the complexity scales there.
But before we officially sign off, I've got a question for you to chew on until next time. We just established that an acute uncomplicated illness is one that isn't resolving as expected, right? But if it keeps failing to resolve, at what exact moment does it cross the line and become an acute complicated illness? What specific symptoms or treatment risks have to pop up to trigger that jump? Something to think about. Thanks so much for hanging out and mastering Table A with me today. Until next time, this has been Decode Healthcare with Harshal. Keep learning and keep decoding.